So we will reconvene and move to the deliberation and voting.
So in a moment, we'll run through a test question to make sure that everyone's voting technology is running properly. So we'll give everyone a minute to get on, and then I'll move forward. If you're having any problems getting on, please raise your hand and Matt can come by. Matt. And once you're all set, it would be helpful if you just looked up at me so I would know who's ready to go. All right. Do you think we're good? Okay, so we'll move forward. Which historical figure did not work at the Omni Parker House? And just to note, the hotel opened in 1855, so it's been around for a long time. So we'll give everyone a minute to vote. If you're not seeing this screen on your phone or laptop, just again, raise your hand and Matt can come by.
I have no idea.
Oh, there it is.
Yeah, 7. So
Gene's not in yet. Great question.
do you know the answer?
I think so.
I don't know.
So it means that 3 of the bits?
So,
Okay, we're looking for 2
Matt.
more.
Gene Ryer.
it had to update.
You too? You're good. I lost the bet.
I'm gonna guess maybe. Oh, it's supposed to be only one. Yeah, that's another one didn't know. Well, it could have been Ho Chi Minh. It's just as good.
And we're at 12, so let's see the results. Well, you were all wrong. The correct answer is Ralph Waldo Emerson. Ho Chi Minh worked as a baker here in, I think, 1912.
Show off. Yes, yes. When did Malcolm X work here, though?
He was a busboy at one point.
Malcolm X?
Yeah. And with that, I can hand things over to Steve, who will lead the moderation of the votes.
All right. Great. I sometimes say it, but I'll say it again. That was the peak of the afternoon, right there. Can you imagine? Your waiter is Malcolm X, your busboy is Ho Chi Minh. I don't know how that would have worked out, but okay. So what we do now is we enter on a phase of voting, discussion and voting that starts with votes around the comparative clinical effectiveness of the agents. It will move on to a discussion of the potential other benefits and contextual considerations. And then it will end with votes on long-term value for money, which again, I'll just highlight now or telescope that without a price known for Zolgensma, we are not going to vote on value, given that we did have a placeholder price in our report, but we don't think it's usually certainly proper to take a formal vote when we're guessing at the price at this point, even if it's an informed guess. So let's start off. And what we have now is, again, we have our clinical experts, we have patient representatives, we also have the ICER research leads here, so that the CEPAC, as you guys deliberate and think through these votes, you can ask questions again of all of the folks at the front table here. So the first 3 questions are in relationship to patients with, again, infantile onset type 1 SMA. So for type 1, is the evidence adequate to demonstrate that the net health benefit, and by that we don't mean cost, we mean net health benefit thinking about the benefits and the risks or potential harms, is that net health benefit of Spinraza added to supportive care superior to that provided by supportive care alone? So for type 1, and again, I will just invite the ICER research team to remind you in your evidence summary, which is tables largely taken from the report to help summarize some of the key points that you'll be walking through in the votes. Alex, would you lead them again through that and the ICER evidence rating?
Sure. So on page 3 and 4 of your summary packets, you'll find the kind of high-level evidence in terms of clinical results for Spinraza and type 1. And on page 8, you'll find the adverse events.
So I can't hear you very well. Can you just make sure to pull that close?
Sure. So again, on page 3 and 4, you'll find the clinical results, and on page 8, you'll find the harms.
All right. And in your broad summary of what those findings show, in terms of mortality, ventilation, motor milestones, what would you say?
So we rated the evidence as an A for Spinraza and type 1 SMA. Again, because of the magnitude of the benefits observed in the trials and the relatively few harms.
Okay. Any questions or comments from the CEPAC about the evidence in type 1 for Spinraza? Okay. All right. I know we've had a chance to think about this a little bit, and there will be questions on which I'm sure there will be some issues to discuss. But let's go ahead and vote if you are ready. Go ahead, and I will be looking. Hopefully it will show up here somewhere when we've got 12 votes. There it is. I see it up there. All right. We've got our votes. 12 yes and 0 no. All right. Good. We're on our way. Next question. Is the evidence adequate to demonstrate for type 1 that the net health benefit of, you can see now the reason that we're using the trade names instead of the generic names. I probably could have learned how to say that correctly, but even if I had learned, I would have probably mispronounced it at the meeting. So it was my request that we all go ahead and use the trade name. So and what's funny is I still don't even know if it's Zolgensma or Gensma. The company may have to tell us later. But is the evidence adequate to demonstrate that the net health benefit of Zolgensma added to supportive care is superior to that provided by supportive care alone? Talking about type 1 again. And Alex, again, if you can just briefly summarize where the tables are and then kind of what they showed for that.
Sure. So here we have pages 4 and 5 for the clinical benefits. And again, the harms are on page 7. And we had rated the evidence for Zolgensma in type 1 as an A. Again, it is a small trial of 12 patients, but the magnitude of benefits and the few harms led us to have the rating of an A.
And can you just summarize again, if you had to put it into an elevator speech, in type 1, what does this treatment show for the 12 patients who received the higher dose in terms of survival, ventilation, major motor milestones?
Yeah, so at the end of the trial, the 24-month period, all patients were alive and none were on permanent ventilation, and that's quite rare in this population in the absence of treatment. And similarly, many patients had achieved motor milestones, and again, that's quite rare in the absence of treatment.
Okay. Clinical experts, I'll ask one quick question. So, sorry, 24 months, was that the duration of follow-up, right, for that? Type 1, which means it has to start, symptoms need to appear before, is it 6 weeks?
6 months.
6 months, okay. So, and I do not remember the exact date at diagnosis after birth of most of those 12 patients, but maybe somebody does. Anyway, is it clear that the natural history of those patients over 24 months would have been ventilation or death for every single one of them?
The natural history of type 1 SMA is undisputably very well described from at least 2 very solidly natural history studies that have been fully published. And the survival at 20 months is 8% without permanent ventilation. And so I think that with such a solid natural history, I think that needs to be taken in account when you consider that, yes, this is a phase 2 with no sham or control, but the natural history, they are very solid. Okay. And also these babies were also screened for some other gene modifier, at least the one gene modifier that is known and they've been tested, so to further even decrease the possibility of single outliers with a milder phenotype. So
Right.
they
So
were
they all
all
had
with two
they had
copies,
two copies or
type
less.
1,
Right.
with symptoms before age 6 months, so very typical
Well-defined
type 1.
group. Okay, good. Thank you. Any questions on this one from the CEPAC panel? All right. I think we have minds made up. Why don't you please go ahead and vote? Thank you. 12-0. All right. Consensus is a beautiful thing. Let's see how long it lasts. So, for type 1, is the evidence adequate to distinguish the net health benefit between Spinraza and Zolgensma? Alex, would you again summarize the state of the evidence and our preliminary judgment?
Yep, so there's no head-to-head trial of these interventions. So again, the evidence is the same as that you have looked at previously. And we had rated the evidence as I, so insufficient, because of the differences in the enrolled populations and the uncertainty there.
Okay. Now, we are going to return to this question in the policy roundtable because no matter what the evidence says, this is a question that clinicians and patients and families will be addressing in the real world. So we'll talk further about it. But right now we're talking about the evidence that's available. Is it adequate to distinguish the net health benefit between the two for type 1? Any questions? All right, please go ahead and vote. Okay, there we go. 12 no, 0 yes. All right, so we're going to move on now to type 2-3 SMA. And here we're going to go back through that same kind of same questions, although there's no data in this patient population for Zolgensma, so we won't have that comparison question. But starting with Spinraza, is the evidence adequate within this patient population to demonstrate that the net health benefit of Spinraza plus supportive care is superior to that provided by supportive care alone? Alex, if you don't mind again.
Yeah, so on page 5 and 6, you'll see the clinical effectiveness, and again on page 7 is the harms. And we had rated this evidence as a B+, in part because the benefits we observed were in terms of a motor functioning scale, but not in terms of survival or specific motor functions attained.
Are you all able to hear her in the back? No. Okay, you're going to have to really pull that close and belt it out.
Sorry. So again, just on page 5 and 6 of the summary packet, you'll find the clinical evidence, and on page 7 is the harms. And we had rated the evidence as a B+, in part because of the clinical benefits that were observed were from the motor functioning as assessed by a scale, and not in terms of benefits in survival or motor functions attained.
So our evidence ratings, just a bit of editorial comment, we try to make them as understandable as possible, but anytime you sum it up in a single letter, it can be a little bit kind of confusing at times. So the B+ again means both an estimate of where we think the best evidence we have, how big the net health benefit is, linked also with the amount of uncertainty. And uncertainty can be either uncertainty because there are more harms in that population, or just less data about the long-term durability of benefit, or any combination of factors. So again, would you explain whether you think the B+ is more due to greater uncertainty, or because the net health benefit is not as substantial in this population as it is in type 1, or some combination of the two? Alex?
So I think in terms of the benefits, again, we're looking at survival and motor milestones attained, which there was no difference in the Spinraza and sham arms. Where there were benefits was in the motor functioning as assessed by the Hammersmith scale.
You want to go ahead? Yeah.
Sure. I'd also add that it was obviously easier to show benefits in the type 1 population because you had hard endpoints of survival and death, of ventilation-free survival and death. So here, where you're having to use motor skills and we didn't have as clear evidence, we weren't as certain that the benefits were substantial, but the B plus says we think it's at least small benefits and potentially substantial benefits.
Okay. Any questions about the quality, meaning, et cetera, of these data? I see Brian maybe having a
I'm
question.
just wondering if the clinical experts could weigh in, since the endpoints are a little softer in this one, if you two could perhaps talk about the benefits of this drug in the type 2 and 3 patients.
Well, for once, I think the mortality doesn't really apply as a rational outcome, in my opinion, because in type 2, that's not really, that relevant. So I will tend, as a clinician, I wouldn't have used mortality, because we know that type 2, they survive for a very long time. The other thing is, the Hammersmith is a very solid, well-regarded scale in clinical trial. This was a, well-controlled, placebo-controlled trial with solid scale. And when it comes to type 2, there is a lot that goes beyond the ability even to walk. When I think of quality life in a patient with type 2 not able to walk but able to sit, it really relies on what they can do with their arms. And because spinal muscular atrophy patients are cognitively extremely intact, and frequently these children are actually ahead of the curve in terms of language, cognitive, what they can accomplish with whatever is preserved upper motor neuron function can actually translate in huge societal type of interaction. So that value, it might not be completely reflected by points in the Hammersmith, but as clinicians, we know that really translates in quite a big difference.
Danielle, I have a feeling you might want to comment on that as well.
So my son started treatment with Spinraza when he was 3, a little over 3. And at that time, prior to starting Spinraza, he started to lose strength in his legs at 10 months, and then continued to lose his ability to get into sitting on his own, stay up in sitting. He couldn't lift his arms up, probably not even this high. He could not open a cabinet or do really anything with his fine motor skills. He could play with an iPad, which requires nothing. So he had lost, and I'm sure there are things that I'm missing, but he had basically, when he started Spinraza, he was not able to stay up and sitting for longer than 10 seconds, 15 seconds. And within the first 4 doses, so the loading doses, when they were complete, he had gained back basically all of his trunk control. So I could set him into sitting and he could stay seated up, which meant he could play with his toys, he could manipulate things, he could interact with his environment and completely differently than he was able to 6, 8 weeks prior. He right away started being able to turn himself while he was in sitting, so kind of push with his hands and scoot around on his butt, which made a huge difference because 3-year-olds want to play with their toys, they want to get their own toys, they want to put Spider-Man and Batman together, they want to do all these things, and I can't read his mind, I'm throwing like all these toys at him just so they'd be right by him. We were like wishing we could put him on like a Lazy Susan, those rotating things on a table so he could just kind of spin and get what he needed. But he was suddenly doing all that on his own. And now he's been on for about a year and a half, and he has gained everything back that he lost. He is pretty much milestone-wise right where he was when he started to get dosed. He's still a little bit weak in his legs, and that if you hold him up, he bears weight a little bit, but not for too long. He's working on that, but he's up on all fours. He can get up on all fours. He can get from laying on the floor back up into sitting. He can get off of couches, safety-wise, like from his bed onto the floor. I don't worry about him falling off of anything. He can use his manual chair, which means he can access so many more places in the community than he can with his 300-pound power wheelchair. That is like, if you run into a step, that's the end. You can't go any farther. So to be able to bring his manual chair that he can use anywhere and we can just pick up and put where we need to go, it has It's changed his life and ours because he's more independent. And none of that can be found in this report. You just wouldn't see it because I understand it's hard to quantify, but it's life-changing for us.
Thank you. Thank you. That's wonderful to hear.
I might also add that some of my patients with type 2 and 3 disease that have started Spinraza therapy used to be dealing with pneumonias that would last for a month to 2 months, very difficult to clear secretions. And since starting Spinraza, their speech is clearer, their cough is stronger, they get over minor illnesses much faster. And it's not always going to be reflected in hospital costs. Well, sometimes it is individual patients, because a lot of care is done just with, really aggressive pulmonologists and home therapies being intensified. But the children they are healthier and safer as well.
Great, thanks. Any other questions? CEPAC? Okay, let's go ahead and vote then, please. Is the evidence adequate to demonstrate net health benefit of Spinraza plus supportive care over supportive care alone in type 2-3? All right, 12-0. All right, now we are moving to pre-symptomatic SMA. All right, so shift gears, shift tables, whoops, what just happened? I'm not sure, did I just go back? Let's see. Nope, yes I did. Okay, here we go, sorry. So, in the pre-symptomatic population, is the evidence adequate to demonstrate the net health benefit of administering Spinraza prior to development of symptoms is superior to that of supportive care alone? Okay, supportive care, because I guess that's what the trial did. Alex, can you again summarize what evidence is available for Spinraza, what it showed, and the evidence rating we gave it?
Yep. So in your evidence packets, it's page 6 for the benefits, and again, page 7 for the harms. Overall, again, this is just a single-arm trial with interim analyses presented. And at the most recent interim analysis, all children were alive and none were on permanent ventilation. And many children have achieved motor milestones.
Okay. So, any questions? David, did you have anything to add, by the way? I don't know if you had a different perspective or wanted to just add something.
I would just comment, if you look at table 3.12 on the motor milestones being achieved, so 2 SMN2 copies is, those patients are going to be type 1, and more than half of them were walking alone for type 1 patients. Nearly all the children with 3 SMN2 copies, who might have been anywhere from type 1 to type 3, were walking alone. Again, this was an interim analysis and it wasn't published yet, so that gave us a little bit of uncertainty, but this is not the natural history of these patients.
Okay, Rob?
So, you're identifying the question we talked about earlier, which is, how do we evaluate evidence that hasn't gone through the rigors of the peer review process and been exposed to criticism, potentially, and scrutiny that would come from experts who would know potential flaws in patient recruitment, trial design, protocols, measurement, all of that. And I think that's a really difficult thing for us to address here, because the question is the evidence not impressive? And it looks incredible. Is the evidence adequate? And, evaluating things that have not been subjected to that process is always something that we struggle with as a panel. Question is, has ICER been able to receive any data or interact with the principal investigators in a way that would make you think that you essentially were able to conduct a peer review or able to ask those tough questions?
I don't think we know anything that the people who are in the room watching the presentation of these data don't know. And in prior reviews, we've often done what we did here, which was drop a level of certainty and put a plus on it in these situations. I don't know if our clinical experts have some feel about whether we should have any worries about these interim data.
Well, I understand from a methodological point of view, it's not a fully published paper, in a journal, but, these data have been presented, for example, in many venues, but American Academy of Neurology, which does have a process of peer review for abstract and interim results of trials, so maybe not as rigorous as the full paper, but there was a peer review for when they were presented there. The data obviously also come from one of the world experts in SMA type 1, has been involved in, all along, so very reputable. That's also the center that has been conducting historically the best published natural history, fully published data for type 1 SMA. So we have that to put in that context. The rigorous, and the inclusion-exclusion criteria are reported fully when you, in this presentation, and I think there is no doubt that there are definitely type 1, well-established, just pure type 1 with no gene modifier, with symptoms, pre-symptomatic, injected before they turn 7 weeks. So the inclusion-exclusion are very rigorous.
That help answer your question? All right, good. Any other questions? No? Okay, please. Oh, I'm sorry, Jason.
No,
go
I
ahead.
guess I think I share Rob's conundrum a little bit with this, because I think a lot of us who do research sort of commonly submit abstracts to conferences, and they're almost always accepted, and there's no back and forth a little bit about the way things are presented. But it sounds like in the clinical community, the presentation that was referenced is sufficient. There's no concerns about the patient population selection or the process or.
Yeah, I think for the data that has been provided to us, we have no reason to doubt that these would be typical SMA kids, and that the natural history is so dramatically different. We don't have major concerns.
Yes, Austin.
Let me ask you, would you welcome me explaining how I'm going to vote, or should I wait till after I vote?
Sure. No, absolutely.
So I'm going to say the evidence is not adequate. And the reason is, if I say the evidence is adequate, then that implies I'm only using the inadequate determination when there's almost no evidence whatsoever. And I think the bar should be just a little bit above that. And so that is not to say this is not impressive. That is not to say that perhaps the intervention is beneficial. But I don't think this is adequate evidence. The bar should just be a bit above 0.
Okay. I mean, there are data.
Oh, yes.
You just mean, okay,
I'm
fine,
saying if
fine.
I say this
Higher
then I would
right.
only say inadequate if it was
Now I
below
understand.
0.
Now I
I'd like to
understand.
see more and peer review and so forth.
Okay.
So
Would
can I-
anybody like, oh, please, go ahead.
Just a very brief comment, and I agree completely. So as a methodology decision, I totally see where that comes from. I'm a clinician in a state with newborn screening already happening. I can have a baby tomorrow with pre-symptomatic type 1 SMA. How am I going to use this data? I'm going to use them as good enough for me that if I can get them Spinraza tomorrow, I'll do it. So it really depends what hat are you wearing.
Yep. That's fair.
Yeah. Any other comments or questions? All right, please go ahead and vote. All right, 10 yes and 2 no. All right. I think that was a helpful comment to hear before the vote. Thank you. And I encourage you going forward, if there are specific reasons that you want to share with the other CEPAC members before the vote, it's very helpful for people to hear your thinking going in. So the next question is about Zolgensma in the pre-symptomatic. Is the evidence adequate to demonstrate the net health benefit of Zolgensma prior to development of symptoms versus that of supportive care alone? Alex, would you like to summarize again what evidence we have?
So we don't have any evidence right now in the pre-symptomatic population, again, just only in the type 1 study. And so we've rated the evidence insufficient because of that lack of data right now.
Okay. Any questions, comments, thoughts about how you're going to vote that you want others to hear? Jean?
So this is a conundrum for me because our
Can you
state
pull it a little bit closer?
I'm sorry. This is a conundrum. Our state has approved newborn screening and it is about to start. If I were a parent of a baby screened tomorrow, would I want them to have access to this, even with insufficient evidence? I'm just raising the question that's in my mind.
Right. I will say that that is exactly the kind of question that we will be addressing at the policy roundtable. Coverage and where there is evidence, especially for in some ways, treatments of ultra-rare disorders does heighten sometimes the tension between the way that the label comes out and where the evidence is and where the use is going forward. So we'll talk about those issues without a doubt. David, did you want to?
I was just going to say that given what was seen in later onset, after it's occurred, type 1, it would be surprising if Zolgensma didn't have effects when given pre-symptomatically. That said, I think safety is an issue until you've proven it. These are newborns. Zolgensma inflames the liver. It's transfecting people. I think before you can know that it's a good thing to do, you need to actually have studied it and proven that it's safe.
So, I'm sorry, I'm going to vote no, but I'm going to say exactly what was just said, that if it were my grandchild, I would want them to get it. I think it's probably good, but the evidence isn't there yet. And I do think safety is an issue. I raised the question earlier about liver issues with gene therapy, and I would agree with David that we just don't have enough evidence yet, I don't think, although it's probably going to be good.
Clinical experts, I'm going to give you a chance in the policy roundtable to address that. And if you feel absolutely compelled to say something now, I'd understand. But believe me, we're coming back to that issue about applications to newborns. Okay, any other? Okay, thank you. Let's go ahead and vote. Is the evidence in the pre-symptomatic population adequate for Zolgensma versus supportive care? 12 no, 0 yes. All right. Okay, now we're going to shift gears, and it's going to get messy up on the slides just because there's going to be a lot of words in small font.
Very small.
A lot.
Oh, yeah.
Apologies for that. But it's done this way mainly because we're going to ask the CEPAC to vote on all that apply, and they have a version of those questions with larger font in front of them, so they don't have to try to read it off the screen. But let me try to summarize both the purpose and the content of this section and the next couple to follow. So in our value framework, if you remember at the beginning, there's comparative clinical effectiveness, and that largely is based on the data that we have, either published or near published, hopefully. We have incremental cost effectiveness. Now, in the broader view of value that we intend this meeting to reflect and to send on as some kind of information to decision makers, there are sometimes, not always, other benefits that might not be captured by that other information, and contextual issues, which there almost always are. So this first slide tries to list a number of potential other benefits, and it's not unique to ultra-rare, it's not unique to Spinraza, not unique to this condition. And I'll run through them briefly, but we're going to have discussion around them, and then, again, the panel will vote on all that apply so that it can be made part of the record, an important part of the record for decision makers. So, and some of these are meant to be comparative, and again, will not have that easy a comparison, so they may not even really apply. The ultimate comparison we're asking the panel to consider is treatment of Spinraza offering one of these potential other benefits versus best supportive care. All right, so it's not compared to Zolgensma. It's versus best supportive care. So the first one, A, is does it offer reduced complexity compared to other treatment options? I will just automatically say that you should rule that one out because there's no other treatment option that we're talking about here. This is a potential other benefit when we're talking about a pill versus an injection or something else like that. Here we're not doing that.
Steve,
Yes.
But how about compared to supportive care?
Yes.
So I think there is a comparison. And if you've got better muscle strength, to get back to the pneumonia issue, the children I see with this, we're giving chest vests to help with airway clearance, cough assist devices.
Mm-hmm.
If they're on a medication that decreases the need for those other devices, then it does show an improvement.
Yes, what's hard is to figure out whether that's captured in the clinical data, which I would think that much of that, I mean, you know, because again, but that could be another, again, the final list here includes other benefits that aren't even listed on this. So in general, though, that A is really meant to apply to a different kind of comparison that we're not making with Spinraza. Jean?
Yeah, I want to push back on that a little too, because an inpatient hospitalization is more complex for a family to manage. It's more complex for everybody. I find it hard to make the distinction that you're asking us to
So I guess
make.
the distinction here is literally meant to compare an active treatment versus another active treatment and whether one has a simpler method of delivery. Through that function alone, it would be a potential other benefit to patients and families. It's not meant to capture the downstream effects on the benefits clinically that would accrue to the patient and family. So all of those things might be real, and you might want to identify them as other potential benefits in the last kind of blank spot there, if you don't think that that was captured by the clinical data or the cost effectiveness, but it's not meant to apply to this one.
So can I
Yes,
just
sure.
propose that maybe the language, because you say compared to other treatment options, which are intended exactly like albuterol, maybe what you meant to say was other disease-modifying treatment or drugs. So
No,
if stated
not
that way, so what do you mean?
Right.
Because treatment options is anything else. Disease-modifying treatment will be a pill or something else.
Right, well, when we
but
talk
modifying the disease.
Right. Just to forecast, what we're going to do, imagine a P&T committee. When they're going to be thinking about this, what we want to make sure we capture is whether there's a competing treatment for which this offers some special potential other benefits. So when we talk about Zolgensma and the fact that it can be delivered as a one-time treatment, doesn't involve lumbar puncture, intrathecal administration, that could be viewed as a potential other benefit. So here we're really talking about Spinraza versus best supportive care. All right. So the second one is actually, I thought we actually had edited these before we came to this meeting, but this one also does not apply. Okay? So this is meant to be used when there's a treatment being compared to another active treatment with a different mechanism of action. So hopefully we've captured in that A and in all the 12-0 votes, we've captured all the clinical benefits that Spinraza has and made a very clear statement about that. Let's talk about C. Spinraza will significantly reduce caregiver or broader family burden. Can I hear from the patients again and maybe the clinicians? The modeling in trying to capture this, looking at productivity, did not find a major difference. And Matt, I can ask you to summarize briefly those findings. But this was not a case in which incorporating the productivity impacts on an average basis made a huge difference to the cost effectiveness, at least. So if we think there are other types of significant benefits on caregiver or broader family burden, now is the time to think about that and to consider it. Matt, maybe you first, and then we'll move down to the patient.
Well, I think you've already summarised it, Steve. It didn't really make much of a difference based on what we included. What we didn't include is another discussion point that may make a difference. But on the things that were included, it didn't affect any conclusion.
Okay, so families? What would you like to say? I mean, the clinical experts have obviously seen this across families, but from within your own sense, does this treatment offer important other potential benefits on caregiver burden and productivity that you think might not have been adequately captured by the data that we've discussed?
I'll say as a mom of a type 1, 100%. We ran a mini ICU in our home, and if we did not have night nursing, I was up all night with my son to make sure he stayed alive. Now, type 1s who have received they have better respiratory support. You know, their ability to survive increases. So, I mean, just for me not having to stay awake to make sure my son stays breathing, which means that I would get to sleep. And that is the very, very, very tip of the iceberg of the potential benefits, you know, trying to keep a child alive. I mean, that's not talking about, you know, fine or gross motor skills. That's not talking about the fact that he was fed by a feeding tube. I mean, he lost his swallow when he was an infant, I mean, a small infant. So my entire life for his 2 years was 100% keeping him alive. I couldn't think of having a job or a social life or even going to the store, you know? So as far as the available benefits and increase to, you know, caregivers' quality of life, absolutely, 100%. You know, room for improvement.
Okay. Danielle, anything you'd like to add?
Well, yeah, I would echo that in terms of productivity. I don't know any family who has not, once they got a diagnosis of SMA, made adjustments to their work load or how they manage that, whether that be getting special, you know, arrangements from your work or all the way to not working anymore. And I have 2 children who are relatively strong when it comes to SMA. They still have a lot of appointments, you know, weekly appointments for PT, of course, and then Landon has OT also. But then if you think of any social activity or appointment that you might make for your child, whether it's health related or just social, there's a ton of work that has to be done before that on my behalf to make sure that the activity that they're doing is safe, that whoever is going to it knows what to do if X, Y, or Z comes up. It's I work full time. I definitely spend, don't tell my bosses this, at least an hour to 2 hours a day. I'm like getting phone calls from people who need to make arrangements for Landon's feeding tube supplies, making arrangements for Ruby's IEP special support at school that she needs. I mean, I could go on and bore you all to death. But my husband actually changed careers in the last year because of this, because I was taking them to most of their appointments and I was just getting so burnt out and stressed out, and I was no good to my family at home, and he was no good, and it's hard on your marriage. There's just a lot of implications to it. But in terms of productivity, yeah, we lost out on my husband's income for 6 months while he changed careers and kind of got the training and licensing he needed to do to start that, and now he will be starting that, but not yet. So that's a whole, you know, salary is worth a year, or from the last half a year that we haven't had, and the SMA is expensive, and you slap special needs or special equipment on any piece of anything, and suddenly it's 800 times more expensive, and so it's just, yeah, there's a huge impact on productivity and how you make ends meet and how you keep sane while you're trying to make ends meet.
Thank you. I think that was very helpful. Any questions, Austin?
It's not so much a question, just an observation that we have 2 questions here, C and D, and I think we've conflated them. So we have broader family burden, and then we have that's C, and then D is about productivity. You know, we will collectively answer the same for both, but they are separate, so we might want to treat them separately.
Right. I think, again, for this one, I would think you can consider your answers to, I mean, again, there's no harm in voting yes on both. There's some overlap. But if you feel that there is a distinct difference between burden and and ability to return to work or productivity, then that's a point you can raise. All right. So I think I will just kind of, in a sense, then skip over D to talk about E a little bit. E actually joins the list of potential other benefits because of something that a representative from Cure SMA said at an earlier meeting of ours, which was, it's hard to capture this, but until there's a treatment, the whole clinical infrastructure doesn't exist to screen, identify, have networks of excellence. It's just kind of a soup where parents end up being the repository of the knowledge about the condition and where they have to kind of create a structure for care. And once there's a real treatment, that can, in a sense, again, kind of catalyze a shift in the infrastructure of care that creates real benefits for patients and families because there's a there there. There's a kind of, again, a system. Often it's a system of referral that gets identified quickly. Screening, again, we'll talk about that later. That kind of comes into play. But even for the kind of current families dealing with the condition with their patients, with their family members, it can create a potential other benefit. So we may not have been able to word it very clearly, and I'm probably still not doing justice to the experience of families, but that's what E is meant to capture. Again, maybe I'd invite Danielle or Brandy to say anything about, and this would be something we could talk about when the representatives of Cure SMA are up here as well, but have you sensed that the community feels like there's a change? I mean, it's just kind of a silly question. Has there been a change since Spinraza came on the scene to the infrastructure of care for patients and families? And if you want to think about it for a second, I bet the clinical experts could say something as well. Yeah, I'm going to go first and then we'll...
Nobody who has been treating SMA patient in neuromuscular neurology wants to retire right now. They have just told their wife and husband, I'm changed my mind. Seriously, you know, this is it's just, you know, as neurologists, giving this diagnosis is one of the worst things we ever have to do as neurologists. But the bottom line that this really reflects neuromuscular infrastructure in academia for the past 2 years had to really reinvent themselves from basically a delivery of supportive care, therefore just major diagnostician. You know all the jokes about neurologists, right? We're good at diagnosis and that's about it. To becoming now inside academic centers, the one delivering some of the most revolutionary treatment, also some of the most expensive treatment. We had to hire new people. We have to train the next generation of pediatric neuromuscular, which are very few. So yes, it's a total infrastructure major change.
Steve?
Thank you.
Yes, Brian. I was talking to Brandy and Danielle earlier that this really is similar to the cystic fibrosis situation we're in, where newborn screening and drugs that are available has absolutely changed how we approach cystic fibrosis. And I'm probably the only one at the CEPAC who's actually taking care of children with SMA. And this is a very different situation going forward that actually is, again, mirrors cystic fibrosis very closely. So yes, I think that having therapies available really does change everything about taking care of these kids.
Okay. So yes, Jean.
So I know this question is targeted to the clinical systems of care, but I live in the world where the rest of the community systems of care, the school systems of care are all wrapped around kids and families as well. And I can't help but, when I look at that, think about how does this affect, for example, how children are interacting with their school systems. What costs are not incurred, for example, by a school system because a child is better able to function. So I know this is a narrow question, but I just want to get the marker out that we have to think even beyond the health system more in our work.
Thank you. Well said. Brandy, did you want to jump in? You just looked at me with a knowing look. Are we good, or do you want to? Okay. So So anything else that we want to say, and this again can be suggested by patients, by clinical experts, or by the CEPAC, are there any other, what you would consider to be an important benefit or disadvantage with Spinraza that you think should be on the table as people think about the broader value? Randy, please.
Well, okay, so my son was born in June of 2015, and of course, it was a terrible fate for him, and my husband and I were terrified to think that we would ever have more children. We were afraid to get pregnant because of the implication that we could have another child with SMA, but honestly, I'm not afraid anymore because I know that there is treatment. Even if my child had type 1, I'm willing to go the distance because there is treatment. So
that's true. I don't think we captured that or alluded to it in our report. And usually what we do, by the way, for these fill in the blanks is we don't usually vote on them unless it triggers a sense of divided opinion to the extent that a vote might be helpful. Usually we record them and include them as significant other potential benefits that people who are thinking about value should include in their thinking. So thank you. Other things that someone...
Well, I don't know
Yes,
if this
Anne.
is some very large costs that get incurred by family that are not generally covered at all by any insurance or anything like that, is like home renovations. Lots of people buy a brand new home because of stairs, and like my daughter is second grade now, so she's like 65 pounds. She's getting a lot heavier to move around and to help if she needs help with something. So home renovations, buying a new home, relocating to a better school district because schools, that whole school realm is very difficult to navigate and feel like your child is being supported and taken care of and given the same opportunity for education as everybody else is. And then also transportation is a huge issue and a cost that gets incurred quite a bit. Conversions for a van run you as much as the van itself, $25,000 to $30,000, and you have to buy the van first. And lots of people don't have the support, or there's no programs to cover that. So you either figure out how to make that work, or you end up very isolated at home. You can't leave your house with your child. So imagine the repercussions that creates for you in other ways, your mental health. But those are some very large costs that people incur that there's not a lot of help for.
Okay. One thing I just want to raise that actually we used to have as a separate vote, we took it out because it seemed like it was almost always the case, but it might be worth noting here. I'm assuming that there's still a lot involved in getting Spinraza treatment. You have to come to the doctor a lot. There's a lot of back and forth. Is it possible that families that come from lower socioeconomic groups, disadvantaged, farther from academic medical centers, are they really burdened as we develop these fantastic new treatments? Do we have to keep our eye on how we make it accessible to people from different walks of life, if you will, different parts of the country, different languages? Is that a tension that you guys are sensing in the clinical community about who gets this now that it's actually available?
Absolutely, 100%. Disparity in health delivery among socioeconomics and racial disparities for us in rare diseases just the beginning, but from other disease models. But we have certainly seen it in the past 2 years with Spinraza. And I can tell you that different academic centers have used different ethics committee, like, when Spinraza became available and you have to treat 100 patients, 60, 40, 4 loading doses, no people that can do lumbar puncture that much. I mean, that's the revolution I was talking about, and that's the revolution of infrastructure. But what about the ethics? Who am I going to inject first? How many can I humanly possibly do? I want to do them all as soon as possible medically. Huge ethics. Do I call every patient on my list proactively, or I just, the well-educated and in the loop that call me first are going to be injected first versus, the non-English speaker with no computer, not well hooked up, or they live 200 miles away from a Cure SMA clinic? Am I going to seek them out proactively or just wait for something to happen? So those were big, huge ethical issues that are still very, very relevant, especially as we look forward, to maybe other treatments. And most academic centers had to come out with their own new, standard of how to approach that. But we need to really be very careful moving forward to, be universally attentive to. And hopefully newborn screening will be a great social equalizer for SMA.
Right. All right, well, I raised it during the section we're talking about other benefits or disadvantages, but that's not really where that should go in this case. I think it's an important contextual consideration around the way that the value is thought about and certainly applied. So we'll include that in that section. All right, was there anything else that, yes, Chris?
Thank you. So I just wanted to add something that I've heard and then something that I've kind of been feeling as, again, I would say, a cut and dry health economist now embracing the world of wishy-washy. And, but the feeling of hope and the feeling of peace of mind and being supported has been quantified to improve a whole host of health-related aspects of life, including fertility, including the prevention of miscarriage and so on. So thing one is, I would say, thank you, Brandy, for mentioning hope. That seems like a very important variable. The second one is, pharma companies have traditionally not wanted to delve into the space of clinical trials for kids or other, very, I would say, value-laden populations. And I think that's an intangible area that I think this sets some groundwork to actually jumping into that area where it's very important. So potentially, we'll see more curative initiatives in the space of children, maternal fetal medicine, and the like. Thanks.
Okay, Jason.
I just wanted to add one potential benefit in my view that's important is that because this disease condition and the specific medication we're discussing, it's an incredibly morbid disease, but then also involves sort of translational science in a really exciting way. There's a basic mechanism, and this is the kind of thing they're going to talk about in basic science classes in medical school in ways that may address, may have significant externalities in the sense that it may inspire more future medical students to go into science and improve the retention in academic medicine of people on grant-funded investigators, which would potentially, over decades, improve the lives of even more patients with different disease conditions. So I think that's an important other benefit of Spinraza.
All right. And we're not going to have a vote on that, but there are broad discussions to be had on a lot of these issues. And that's one, just because other benefits always have to be viewed, I think, or in terms of the potential opportunity cost as well. Because everything that's potential other benefit here, if more doctors are going into this field, will they abandon primary care or geriatrics? I mean, you can create these kinds of nobody wins at the end scenarios, or a zero-sum game, I guess. But I do think that you're right, and I heard what you said, and I'm sure that's true, that this is totally scintillating to young medical students and others who are thinking about their future careers.
Can I make just one very
Yes.
brief comment about the broader family burden?
Please.
Probably many of you, this is kind of obvious, but serious chronic diseases such as SMA, they are really family diseases. I mean, there is the patients, but there are the siblings and the parents, and the broader burden of having to soldier up and deal with this mental illness, other siblings that inevitably, suffer from all the attention that needs to be given to the child who's, has to deal with this. So that's kind of a broader burden, and if you add to that equation hope or intervention or some sort of hope, how that can really make a difference in the overall health of the whole family dealing with this.
Okay, now we're going to run through contextual considerations for Spinraza and then flip over to Zolgensma. So we're going to need to, I'm going to try to do the right balance again of getting comprehensive but moving us through in a way that we can complete this. So I think we are at the point where we can vote on this. And what I'd like you to do is to go ahead and vote on all that apply. You don't have to, we've captured F, so basically A, B, C, D, and E. All that you think apply.
I thought you said we weren't supposed to vote on A and B.
Oh, I'm sorry, you're right. Thank you. So C, D, and E.
Steve?
Yes.
I'd just like to make one point. I somehow thought we were going to talk a little bit more. I want to go back to the equity issue.
Yes.
I think that that's incredibly germane. When you think about quality of care, one of the 6 domains that the National Academy of Medicine called out in 2003 was equity, and equity has become more and more something that people think about. And so I see, the potential for a disadvantage of making things more inequitable, and I just want to flag that as a comment here.
Excellent. Okay, please keep going. And this is one where I will not know when everybody's voted without just looking to see if you're looking at me. So if you're looking at me, that means you're finished your voting. Wow, that was fast. Oh, Martha's still voting. Has everybody else voted other than Martha? Okay. No pressure, Martha.
We're not voting on F.
Correct. Just C, D, and E. Martha, you all done voting? Sorry, you voted? Okay.
Yep, sorry.
That's all right. Okay, so we've got 12 out of 12 for C, 10 out of 12 for D, 12 out of 12 for E. All right, thank you. That was a very helpful discussion. Many of these points will be applicable to our thinking around Zolgensma, and there might be some other things as well. But let's turn to the contextual considerations. So these are generally meant to capture some of the, again, factors of the context, and they include really important things such as, is this intended for the care of individuals with a condition of particularly high severity in terms of the impact on the length of life or the quality of life? Because we all know that you can get an improvement in health from near perfect to perfect, or you can get it from very, very sick to a little bit less sick, and we may want to have people viewing the value as making a distinction between those two or not. So, is it high severity in terms of impact on length of life or quality of life? B, is a particularly high lifetime burden of illness? C, was Spinraza the first to offer any improvement for patients with this condition? And then we ask kind of contextual questions about uncertainty. These are tough because they're frequently hard to know how to quantify. But compared to best supportive care, is there significant uncertainty about the long-term risk of serious side effects of Spinraza? And compared to best supportive care, is there significant uncertainty about the durability or the magnitude of its benefits? And then we have a fill in the blank as well there. So for the context, I think I'll look to the panel first, perhaps, to see if you guys have any thoughts or questions or wrestling with your vote on any of these.
Well, I think that the long term is an issue. We just don't know. The data that was presented, and I think the pharmaceutical people who spoke talked about longer experience and greater experience with worldwide stuff. But in terms of the data we've been presented, it's all about 24 months or roughly that, maybe even less, in very small groups. So it's really hard to know about long-term efficacy and long-term safety.
Okay. Martha?
Yeah, well, I found this hard because compared to best supportive care, which doesn't seem to be very useful, that's pretty certain. I don't know how to think about significant uncertainty about the long-term effects because I'm comparing something which certainly has a bad outcome.
I guess partly that's to capture certain situations where we might have a treatment that's using the same mechanism of action and is to a drug that's been out for a long time. So we really don't have that much uncertainty about the long-term risks. We might have more uncertainty about the benefits, but the risks are kind of well established for that type of treatment. That's one scenario that would have, maybe different votes here. So it's kind of looking at the context. Do we have significant uncertainty about the long-term risks and or benefits for this kind of treatment? Yes?
I'm not sure if it would be helpful for the rest of the CEPAC to hear, but...
Sorry, can you pull that a little closer too?
Yeah.
Would it be helpful if Alex or David reminded us, or maybe Matt reminded us about the long-term motor function milestones? Because we do have data that's beyond just the 24 weeks addressing Spinraza.
Alex, you want to tackle that one?
Yes, so we have longer-term data for the patients that were in ENDEAR, so in type 1, who then transitioned to SHINE, which is the longer-term extension study. And so in your evidence summary packets, that's on page 4, in table 3.6.
So just since I'm not finding it fast, what is the longest duration of durability of effect that we have with Spinraza?
So there's up to 689 days, but of course not all patients have been followed up for that full period of time. So you'll notice in the first row on that table, the number with available data has declined over time, and that's for administrative censoring mostly.
Okay,
Just so I can ask on that, I'm realizing I don't perfectly know the answer. Is that 689 days after the trial ended, so that it's longer than that? Because 689 days is very close, obviously, to 2 years. So is it 2 years beyond? That's just the total time.
Okay, so let's go ahead and vote on the contextual considerations. And again, the way it's worded, are any of the following contextual considerations important in assessing Spinraza's long-term value for money? So it's an all that apply, and you don't need to vote on F. So A, B, C, D, and E. And again, I'll look to you. I know it'll take you a little bit of time to do the voting, but when you're done, just look up at me, and I'll try to assess when we're all finished. Okay, gotcha. Someday we'll have technology, a little green light will show up on your table, and I won't have to do this. I think we're done. Everybody? Austin, have you finished? Okay. All right. So over half for each of these, but very near unanimity around A, high severity, B, long-term burden of illness, C, first to offer any improvement, and uncertainty 7 and 7. Okay. Given the time, let's go over to Zolgensma. So in some ways, the conversation might be quicker, but I do want to highlight that here we are talking about it. Let's see. Should we have them vote on this versus best supportive care or versus? The hard part is that there are both questions to be held about its kind of comparison to best supportive care or to Spinraza. Around mechanism of action, for instance, or complexity. So let's just go ahead and say that, because we're just trying to send this as a signal to decision makers. So A is going to be certainly versus Spinraza, other treatment options. And the others are going to be about versus usual care, best supportive care. All right. And in that sense, again, if you think there are distinctions between its effects on any of these as potential other benefits, as opposed to Spinraza, you can certainly raise that as a question. We'll go ahead and do the vote. But otherwise, I think, except for question A, which I'd like you to go ahead and consider in comparison to Spinraza, let's go ahead and vote on the rest compared to best supportive care.
I was going to ask a quick question about C. I don't believe we have any data, but in terms of an alternative treatment for patients that have failed, the other alternative.
Well, we could have asked the same of Spinraza.
Exactly.
Let's hold that to the policy roundtable. So in this case, it actually kind of doesn't apply. Yeah, it doesn't apply.
Because we're comparing it to
In that one, you're comparing it to supportive care. Okay, does anybody have any questions?
Stephen, are we voting on C or not?
No.
Okay, gotcha.
I mean, it remains part of the list, but I'm instructing you not to vote for it.
Not taking C? No C includes C.
Because it's meant to capture a different situation. Well, we're just taking a second. Some people are probably going to be voting. But from the clinical expert's perspective, and this will verge a little bit into the policy roundtable, but if you were to describe the complexity of the treatment with Zolgensma versus the complexity of what patients and families go through with Spinraza, how do you frame it?
Spinraza is very complex. Although, you're dealing with a very serious disease, so I've seen that the new normal, when you have a terrible disease, the burden needs to be taken with a grain of salt. But from the health provider, very complex, requires a lot of infrastructure. You cannot do it in your, around the corner pediatric office, so to speak. Gene therapy is a BLS biosafety 1, so it's an IV infusion, can be done as outpatient.
So we raised that question here. Does the fact that it's administered as an IV, will that make it easier to access in rural communities or disadvantaged communities, or does it make no difference? Is it such a
I
complex?
will definitely not envision doing gene therapy in community-based practice, but I think that these are very complex treatment that belongs to specialized centers, because it's not just, giving it, it's also everything that comes with it, so being able to follow side effects and so forth. But yeah, it's an IV one time, that's obviously it's simpler.
Okay.
So can I
You will.
interject there?
Yes.
Representing the rural parts of New England.
Yes.
It would mean just one trip to the specialty center as opposed to multiple trips.
Absolutely, it doesn't even require an overnight stay through, it's just.
Although we'll talk about the follow-up trips to see how it's working and whether that's going to be part, obviously, of both payment and other aspects of clinical care. Okay, so let's go ahead and vote on the potential other benefits for Zolgensma, A, B, C, D, and E, with C not really being a consideration. Okay, is everybody done? Yes. Okay, somebody voted for C. I can't believe it. 12, I hope you weren't somehow just getting the wrong vote on the wrong key, but 12, 11, 10, and 11. All right. If memory serves, that's very similar to the Spinraza votes. Okay, and for contextual considerations, again, here, there really shouldn't be a difference from your votes on Spinraza, just to make it completely blunt, because this is about the context. I guess I shouldn't say that necessarily. It could be that you have a different view of the uncertainty about the longer-term risks or the longer-term durability of effect, so that very much could be distinct for Zolgensma. But I would guess we don't need that much discussion, and I'm partly saying that because we have the value votes ahead. Okay, please go ahead and vote. You guys are getting quick at this. Is anybody still voting? Okay, I'll wait. Okay. And it is very, very similar. Okay, well, we'll have to hear about the E's later. But we've got 10, 10, and I believe it was 7 and 7 the last time around, so it's still very similar to the two. Okay, so apologies for moving quickly past something like that to the overall long-term value for money votes. All right, I have to have a little bit of a preamble to this. And it's really important coming after that part of the meeting. So there is no right way to use English to describe what we mean here. Long-term works. Value for money is tough. Are we talking about whether this treatment works? No. Are we talking about whether patients and their families feel like they've entered a new dawn and a new era with all of the changes that we have talked about? Are we talking about whether there's value to them of having these treatments available? No. We're talking about that in proportion to the price, to the cost, over the long term. So it's not value. It's not whether we think the patients and families, again, are benefiting from it, whether we want it to be covered. It's about none of that. This is trying to take all of the different factors that we have talked about, the comparative clinical effectiveness, the incremental cost effectiveness, potential other benefits and contextual issues, and putting that into a scale, a proportion, to seek that balance that I guess I referenced at the very beginning. So this is really hard because, again, English doesn't work. When you say long-term value for money, it's very hard not to hear different things depending on what perspective you're coming from. But the for money really is a key part here. And partly I'm saying this because we want to be very clear that the panel's votes, if they happen to vote low value, that does not mean that they don't think these drugs should be covered by insurance. It doesn't mean that they don't think the drugs work spectacularly. It doesn't mean any of that. It's looking at that effect and the broader issues in proportion to the price. So I hope that was a lot more English than long-term value for money, and it may still not be that clear, but I wanted to try to set the stage because I know how hard it is sometimes to get past the idea that this means that it works or doesn't work or that people should get it or shouldn't get it. That's not on the table here. Okay. So let's have a discussion among the panel. This is, again, with a lot of words up in the beginning of this question, taking into consideration those different factors. What is the long-term value for money of treatment with Spinraza versus supportive care alone in type 1 SMA? Matt, would you mind just reminding them what the findings of the economic model were?
Yes, so they're on page 9 of the evidence summary document. So you see there the cost per QALY gained is over $1 million. The other metric that we've evaluated, the cost per life year gained, was approaching $600,000.
And also, you did a bunch of different sensitivity analyses, varying different aspects of the model, and this is the one where I believe 0% were below 500,000, is that correct?
Okay, there's two things. One's the tornado diagram, but I
Right.
assumed once you're on that page you'd see it. So the tornado diagram is just changing each parameter one at a time. These are the key ones, and you can see that it never fell below 950,000 cost per QALY gained. Then we also did the probabilistic sensitivity analyses to get the base case results, but it also gives you an idea of the uncertainty in there. And on all of the cost per QALY thresholds up to $500,000, it had a 0% chance. So from every PSA iteration we ran, it was 0%.
Questions?
I just wanted
Comments?
to add that long-term or any term value for money should be viewed within the context of willingness to pay.
Mm-hmm.
Are we, as voting members, supposed to be taking the view of the health insurance payor?
When you say the view, so there are
I mean, yeah.
the modeling is,
perspective
if you talk
of-
about the technical aspect of that question, is whether the perspective is one on the health sector, where the costs of hospitalization and doctor's visits and the impact on health is kind of what you are comparing. There's a modified societal perspective, which does look at productivity and other factors to the extent that you can try to measure them. And those results were presented earlier. They were not that different from these findings that you're seeing here.
They're also on page 10. If you
Oh,
want to
they're in
see
there too, good. Was that your question?
Well, I think it depends who is being asked this question. I mean, certainly for a physician, the physician's role is to advocate for the patient. we have patients and caregivers who have a different role and a different view, and would answer this question differently.
Right.
We have the health insurance payers who would take a different perspective, as you put it, and then there's society. And how to, whether we're expected to take all those views and somehow compare apples and oranges and put them together and vote on a value, or whether we're supposed to take the perspective, as we've done in the past, of the insurer perspective.
It's really what I would say, it's the health system perspective. And that by extent, if we're talking about Medicaid, many of these patients will be treated with Medicaid, right? Or they may be disabled, maybe they're on Medicare, they're dual eligibles. Or it could be a public payer, or it could be a private payer. And they, in a sense, in our country, they reflect the way that we as a society have organized the health system. So in a sense, we are asking about value for money from that perspective, not from the clinician's perspective, certainly, because they're not personally responsible for the broader population cost effectiveness or balance of what we can do with the available resources. Certainly not from the individual patient, and that's what I was trying to say. This is not about whether a family thinks that for them this is a good long-term value for money. It's from the health system's perspective. And that's why the cost effectiveness modeling is done from that perspective in particular. Brian and then Jean, sure.
This is the one I always struggle with the most, because I think the benefit, and again, you've already described this, for the individual child is unquestionable. And so long-term, that may be very cost-effective in terms of hospitalizations, but the problem is the price. And as we have more and more drugs that are priced astronomically high, the society can't sustain this. It becomes a huge issue. And we all want all of these kids to get these drugs, but we can't, as a society, afford every medication to cost $1 million. So it's balancing the individual need and the societal need that I find so hard when it comes to this question.
It is. Jean?
So I'm glad Brian said what I usually say, which is it's the price is stupid. Not to quote UV Reinhardt, not calling anybody stupid, but so we could afford a lot more of these drugs if they didn't cost so much, and then we wouldn't have a lot of these issues. But could we come to, what is our common understanding of what willingness to pay is in this context?
So you always ask me the hard questions. That's an easy one. So as I think many of you will remember, there are different ways that ICER and health economists generally try to think of. You can always measure the outcomes with life years and quality of life and sum that into a quality if you wish, or life years gained. You can measure the costs. To put them into some kind of proportion, there are different ways to do that. Some people do call it willingness to pay, and that can be decided by aspirational goals. How much should we as a country be willing to pay? Everything? 50% of our GDP? Should we be willing to pay that if it provided better health? Is willingness to pay reflected by the decisions we've already made in the past? Or you can do surveys of individuals. How much of your salary each year would you give up for an extra life year at the end? They've actually done all of that. And other health economists tend to scale it to the wealth of the society overall. And those who do it that way will usually say it's somewhere between 1 to 3 times the per capita GDP per quality. But that's pretty arbitrary. It's still been used by doctors groups and others around the world, but it's still pretty arbitrary. The surveys of individuals, interestingly enough, most of the time you'll find that they're willing to give about 2 times their annual salary for a quality, so it's about 2 times their per capita, if you will. And then more recent empirical evidence done in other countries, at least, where they actually have healthcare budgets and they do try to figure out, if you bring in new expensive things, what don't we do because we have to pay for the new thing. That evidence is continuing to show that the threshold should be lower, around 1 times the per capita GDP or lower, to match the true opportunity cost. So health economists will strongly differ about whether you should use a willingness to pay or an opportunity cost. We have our threshold between 100 to 150 because there's no one bright line, and that's at the kind of higher end of the willingness to pay scale. It's too high for those health economists who think we should be looking tougher at opportunity cost. But that's where we are today. And as you've heard other comments, some people believe, and we know historically, that some decision makers in treatments of ultra-rare disorders will look at some of the contextual issues and go higher. But that's, again, quite variable depending on the situation and how much higher. There's no kind of normative approach to that. So our value-based price range, as you know, we've put between 100 to 150, but we have a lot of our report and these discussions to hopefully bring nuance to that. We know that you're wrestling with uncertainty because those are based on long-term estimates of the durability of the effect. It's based on a lot of factors of the modeling and all of the other benefits and kind of contextual issues that you've heard. So that's why it's still a hard decision. Yes, Martha. Martha, by the way, was at the ground floor of a lot of this thinking in the U.S.
And she's lost a lot along the way. I'm just taking a little bit issue that this is the health system perspective, because you've asked us to think about contextual considerations, which to me are much more a societal perspective. So I just want to clarify.
So we're cheating, you're right. We think the health system ought to think about those things.
Uh-huh.
We think that insurers and others, and you'll hear from them later on the roundtable, we know from them that they do listen. They don't just read, they listen to these meetings and they read what comes out. And they want to know about these contextual issues because the better part of their angels recognizes that they exist as a function of our society, and they have a higher mission as well.
But if we're folding it into our appraisal,
Yes.
it does get a little squishier,
It gets
become
squishier.
a little more societal.
It gets squishier.
In its thinking.
And again, some people will view that squishiness within the 100 to 150. There's a range there. Some people will feel the squishiness extends much further. And that's where, again, it gets more difficult. But that's why each case, in some sense, should stand on its own feet, because there are different contextual issues for each topic. Claudia?
We're dealing with a rare disease.
Mm-hmm.
So in looking at the long-term value for money, if we're dealing with a rare disease that we don't have to treat that many children for, can that also be taken into consideration as a contextual consideration in spending more money? Again, if we had some discussions about the QALY and really what our limits should be, but that might be a consideration of a contextual consideration that may change our evaluation of the situation.
Yes, and again, part of it depends on how many is a lot. So if we had 5 patients, or if we have 200,000, which is the upper range for orphan conditions in this country. And what's interesting is that and you'll get different histories about this, but the whole idea of treating orphan drugs differently in some ways was because of a perceived issue with the ability of companies to make enough money back, that it would be literally impossible for them to do so on such a small basis unless they charged high prices. Some people will argue that we're in a different era now, where if you have 10,000 patients and it's a $100,000 a year drug, that's $1 billion. So you're getting a blockbuster out of 10,000 patients, which is a pretty small patient population. So there are reasons that some people believe that the orphan argument is a valid one in contextual issues around value and pricing, and some people who aren't so sure. And they're also now realizing that I think it was 40%, 30 to 40% of new FDA approvals were for orphan conditions last year. So the old context around that argument has been shifting over time, but it's still, you're right. Is it part of the context of thinking of that? Cost effectiveness doesn't think about how many patients we're multiplying it by. But again, you can imagine that some people would say, small number of patients, big number, still doesn't come out to be that big of a budget impact. It just depends on whether you think those resources could be used elsewhere better in the health system, whether we're sending the right signals. I don't want you to think about too many of these other factors, but that's part of the argument around why the range for ultra-orphan diseases, in some cases at least, we think, at least policymakers should view that there's an anchor with the usual range and then think about exceptions or different features that may want to move them. But that there's a reason that there's a range that represents where we should try to be. Brian, and then I'm going to apologize because we're eating into the policy roundtable mainly.
Well,
because
this may be a policy roundtable
okay.
question. And that's the elephant in the room that we're not talking about is the initial price that's being set. We're talking about what happens to the children. We're talking about the clinical benefit. But who set the price? Why did it get set? And what would the quality threshold be if the price were set lower to begin with? And I understand companies have a fiduciary responsibility to their shareholders. They have a fiduciary responsibility to patients too. And I think that's where, and to society, and I think that's where the issue comes up. And we've kind of danced around all of that.
All right, Brian, you cheated. You got in a policy roundtable statement before the policy roundtable. We're going there. All right, let me be harsh because I know this is a rich conversation, but we've had a good one. Let's try to go ahead and take the vote so we have time to consider some of the other votes on value as well. So, type 1, Spinraza. You've, again, been shown the cost effectiveness results. We've had the rich discussion around other benefits and context. And I will be able to see when I have 12 votes. Low long-term value for money, 12-0. Okay. Let's keep going. If we have time, we can circle back for further debriefing on the votes, but when it's unanimous, I think I'll keep going at this point. So now, where we have data for Zolgensma from the studies on type 1 SMA, you have the same question, and again, oh no, this shouldn't be here. Because we didn't have the data. Someone voted before this. You were quick. Hold on, hold on. This one shouldn't because we... No price. Why am I... that's why we're not voting on that. Okay, so we're back to... Apologies again to all the people from Avexis who wanted us to vote on the value of your agent. I will ask you on the round table what the price will be. I'm sure you want to make that announcement today here with us, so we'll ask you that. But Biogen gets to be the object of our desire right now. So 14, this question is for type 2-3 SMA. Matt, can I ask you to again summarize briefly the cost effectiveness findings?
Yes, these are on page 10 for the healthcare sector results, and spilling to page 11 for the modified societal perspective. The results there look suspiciously the same, which has fooled me somewhat. But in both circumstances, the ICER that we're looking at is very, very high, above 8 million cost per quality.
This is the 8 million one, right? Wasn't it? Yeah, 8 million, right. 8 million per quality, okay. Okay, I think we had, again, the discussion about thresholds. So unless anybody wants to raise a new question about this particular vote, okay, please go ahead and vote. One more.
She's working on it.
There we go.
Sorry.
It's okay. 12-0. I mean 12-0-0. Okay, low long-term value for money. Okay, is this the pre-symptomatic one? I hope it is. Yes, this is it. Okay, so pre-symptomatic, shifting again to a different patient population. So this is about the use of Spinraza before symptoms develop versus best supportive care. Matt, hopefully you have the numbers at hand.
Yes, these are pages 11 and 12. As we presented earlier, the base case results in the pre-symptomatic for Spinraza, that's where they're the lowest. The cost per quality gained is slightly over $700,000. And for life years gained, it's 650,000. You'll also see the tornado diagram, as we did with type 1. Again, it doesn't come below $675,000 for cost per quality. Turning over the page, you have the modified societal perspective, which is slightly lower, still no less than $600,000 for either cost per quality gained or cost per life year gained. And finally, the final table in your evidence pack is the threshold price for Spinraza in pre-symptomatic SMA at different threshold prices of cost per quality. So just to give you a context, if I just do it in terms of cost per quality.
That's right, we don't actually need to get into that.
Okay, you
That's
want to
okay.
leave it? Fine.
Actually, Matt, will you remind me, what, the vote on the clinical effectiveness for Spinraza pre-symptomatic, was the vote on Spinraza pre-symptomatic, was it majority and yes? It was 10-2. It was adequate or inadequate? Adequate. Okay, I just wanted to make sure. For some reason I thought that one was inadequate. All right, so this is the use of Spinraza that has the best cost effectiveness for Spinraza, but you've just heard what the results were. Any questions about the modeling in this particular subgroup, the evidence or anything that you want to raise? Chris.
Just a very small typo on table 4.29. So I think the cost per quality gain should be 8,198,936.
We will follow up on that. So it's still over $8 million, but it, okay, maybe we transcribed it.
So it does not change the conclusions, it's just a...
Okay,
Yep.
picked the wrong table, got it. Thanks. Okay, please go ahead and vote. Long-term value for money of Spinraza in the pre-symptomatic population. Okay, low value. Low long-term value for money. All right, thank you very much for that discussion. We are going, the meeting was supposed to reconvene at 2:15 after a short break. I think we are going to need at least 10 minutes, so I'm going to, let's restart things right at 2:20 when we'll have the chance to have the policy roundtable. Jean, did you want to have a comment about the votes?
Yeah, I want to make a point to the family
Please.
members, which is that those last few votes are about the pricing. They're not about the value of, the clinical value of these drugs, the value in your lives. I just want to make sure that you're really clear about that.
Thank you. It was a good bookend to my opening.